So welcome everybody today for this exciting 10th episode of our webinar series. On behalf of SigTuple, I would like to welcome and thank everybody for taking out their precious time on a Saturday evening. And today, let me tell you at the very outset itself that it's going to be a power-packed session. We have a very distinguished speaker amidst us today, Dr. Chaitanya Khillare from Udyati Labs in Maharashtra. And he's a distinguished pathologist in his own right. You'll find him to be very humorous as well. And also you will see how beautifully he brings out the morphological analysis with deep insights. They are going to be like golden nuggets that you will be carrying back today, and how he actually matches them with the impact with clinical diagnosis and the impact as well. So looking forward to this session with Dr. Chaitanya. But before I hand over the stage to him, I would like to just give you a brief introduction about SigTuple and our company and what we do out over here. As you know, SigTuple, we are engaging with the automation of the manual microscopic view, which digital pathology on an AI-based platform, cloud-driven. And this is something that we have brought about to make the whole process of peripheral smear reporting more efficient, consistent, and accessible. So what we are really trying to do over here is automating the error-prone, inefficient manual microscopic review by democratizing the microscopy and enabling the AI assistance with remote review unhindered by geographical boundaries. For example, if I'm sitting here, right here at home today, I should be able to see visual evidence on a cloud-based platform and looking at the AI-driven diagnosis or the report which is given by the AI, the findings which is given with that. I would like to correlate that with the image-based evidence and give out my report all within a few minutes. I'm going to leave this to Dr. Chaitanya at a later stage to really show you how this happens in practice today, and that too coming from a setup like where he comes from. And it's about the bread and butter of the daily cases that actually make an impact. So we have all the great diagnosis which comes out, right, of leukemias and lymphomas and whatnot. But where the errors are is in our routine diagnosis, in our routine cases, which hits us day in, day out. And some of them, mind you, can actually be critical. And some of them can be very fatal as well if misdiagnosed. And that is what we are going to be discussing today, and how it actually impacts not just the decision that is made by the pathologist, but also the impact which actually goes on, to giving the clinician that diagnosis, and what further management and what are the further evaluations that one can do once we get a diagnosis from that. I'm not going to dwell too much on the opportunity of the hematology opportunity that we have in SigTuple with AI 100. That's something I think I would like to allow Dr. Chaitanya to actually cover that up in his own words today. But yes, we are looking at the analysis of peripheral blood smear, all driven with AI-based assistance on a cloud-based platform. And we are stain agnostic, and you can use any of the Romanowski stains today. And the results that the AI will give you is of WBC morphology, RBC morphology, platelet count, and platelet morphology as well. We also have our research parameter, which is malarial parasite. And all of this is something I think in real life cases which Dr. Chaitanya will be discussing with us today. So we have one solution with, we have got one hardware, and we've got a software-based platform, which is called as Mandara. And you have the two solutions all on one device. We have both Shonit as well as Shrava. Shonit is the peripheral blood smear analysis, whereas Shrava is for urine microscopy. Now, both these solutions are available on one device as well, which makes it very economical to use. And what we're looking out for is accuracy, accessibility, affordability, standardization, reproducibility. And finally, what we're trying to achieve is quality-driven healthcare, which I think Dr. Chaitanya will tell us today in his own words. Let me skip the next couple of slides. The last thing what I would like to actually highlight out here is the microscopic view, which I think Dr. Chaitanya will also resonate and mirror the feelings that I have when I talk about this particular feature of what Shonit can actually provide you, is this incredible software, which with a simple scroll mechanism, you will be able to go from different buckets and look at all the WBC morphologies with a patch view as well as a microscopic view. So you do not miss your microscope. You will be able to transit easily from manual microscopy to a digital based way of reporting, all because there is visual evidence and you have your clinical acumen to correlate with that, what you are seeing out over here, and give the interpretation within no time. Again, we look at WBC morphology, where we give you the 7-part differential. Along with that, you have the NRBC count as well. And when it comes to RBC, we give you the RBC size as well as the poikilocytosis. And then when it comes to the platelets, we give you the count as well as the morphology. The similar feature can be seen for our urine microscopy as well, where we give you the semi-quantitative grading for RBC, pus cells, epithelial cells. We give you the cast crystals, microorganisms, and yeast as well, all of this detected versus non-detected. And again, it all comes around with this incredible microscopic view. Now, this is the view which I like, and I think Dr. Chaitanya will also agree with me when he's going to be talking about it. So when you can zoom in, zoom out from various areas of that field, be it the feathered edge, be it the discernible area of the smear, and all the way up there to the thick area of the smear, where you get a wonderful count of 100 cells or 200 cells or 120 fields of view, which is the entire discernible area of the smear, gives that confidence to us as pathologists when we are not even there at the lab physically. And so it obviates the need to be present physically next to your microscope, next to your smears. You can look at these smears even if you're not in the lab, especially in the early morning hours or in the late evening hours, or if you're traveling for a conference. So these are things I would like to hear from Dr. Chaitanya himself today. So please join me in welcoming our distinguished speaker. I'm very happy to introduce him here today. And so before handing out the stage to him, I want to tell you that he's renowned for his clarity of thought, the rigor in his diagnosis, the clinical acumen that he comes from, and also the humor in which he will actually tell you about these cases and make you feel that pathology can be so exciting. So over to you, Dr. Chaitanya. Thank you very much for agreeing to participate with us in this webinar here today. And yes, the stage is open for you, and we're all looking forward to hearing from you.
First of all, thank you, Dr. Renu, uh, for giving me a big opportunity to share my thoughts on the AI. So here I go. Basically, I kept this slide blankly like this because we know these are the slides we smear see under the microscope, but nowadays these RBCs are coming pop up in AI machines, and now we can learn this. Before starting, I always share thanks to whenever I do in my lectures also, where I go to speaker as also. I would like to share thank you before the ending of my slide because I am here today because of these people. Gokte ma'am was my HOD who gave me first opportunity to handle the AI. Joshi sir was my guide. Khushbu is my wife. Shivkarna is my partner, and because of whom I can do all my adventurous tricks. Patil sir is my one of the best guide and friend throughout my life, and Rajendran sir is the one who introduced me to this world. Not physically, but right now today we are discussing digitally. So one of the video I saw from him, I followed him on Twitter and I learned a lot from pathology. So definitely thanks to the sick people and thanks to everyone, the audience being here and giving me such a big opportunity from bottom of my heart. So before starting this, I said thanks because this is usually I do. As we go to the end, we may not remember the many words. So that's why I started with a thank you from bottom of heart. I don't want to give introduction about myself now. So this talk has been divided into three parts. First is you can see the traditional words. Second is the four real cases, because actually if I started to take you through how exactly AI works, it will be difficult to understand. It will become more technical. So I think I will take you through my hit cases. And then lastly, what are the new problems? Because with every machine, we get a new problems. So that's how I'm going to start this. So give me a 2 minutes. I will set my clock because as I'm a lecturer, so once I started, I will not stop for more than like I will go 60 minutes. I don't want to go for that far. So okay. So my journey started in 2018 uh, when I joined as assistant professor. In 2019, everybody knows this COVID hits everybody. We were not having so much samples in a lab, so I started to handle the Optrascan and the Aperio CS2. That time, the two digital scanners in one medical college was a big thing, and my HOD allowed me to handle this. I took a training for 6 months. I played with that machines literally, and with that, I come to know the world AI. In 2019, first time I wrote my first review article on AI. I shifted from Pune to the Parbhani, and it is a joint venture lab. So in 2024, first I brought, in fact, Urisid Mini was my first AI machine for urine. And then I jumped within a 10 days, I decided to get AI 1000. This was the machine actually I am following since 2020, I think. And then now we have started even CASA SIM analysis also. That is also AI integrated. So coming to the traditional lab workflow, everybody knows that either we will get the sample from someone else or either we will get a walk-in. So same here, it comes as a walk-in or it comes as from somewhere else. I have a three-part machine WinRay. So we run the sample. If we needed, we get a smear, stain, and see under the microscope. So what are the main disadvantage of this all uh, things we are doing? The traditional way, we need our physical presence, and trained or senior technician staff is the biggest issue right now, at least at my area. I don't know other places, but for my place, because once you get a trained staff, they will either raise their payment, they will keep you waiting for them, or else you have to train them. And once you train them, they will leave your lab. So technician change, your smear quality change. Technician change, your stain quality will change. So this happens usually, and these are the biggest problems I was facing. I'm facing now also for other tests. And second thing is, see, I am not from the place where usually we get daily 5, 6 leukemias. In institute level, it's okay. We can take a chance from associate professor. We can get advice from the professor. But at a small town, you have to take from 10 year, 5 year, 8 year, or 2 years experience person. We usually share the case. Those who are 10 or 5 year experience, they will not share the case. They will directly sign out the report because they got experience now in private. But for me, I get into this, then we will take like, sir, I got a case, what do you think? Or in case even I have to take a decision from or second opinion from my partner also. So what happen usually in that, someone say, I got this leukemia, blast like cells. Someone say it is reactive cell, or sometimes we need, okay, I need a special stain. Someone say it is okay, leukocytosis, bone marrow, or flow cytometry is needed in this case. So such kind of things happens because of intra-observer error. So one, technician problem, and second, intra-observer error. These are the two things always be a most important hurdles in your day-to-day reporting in hematology. And uh, yes, definitely, I know you are saying what you are saying us. There is nothing new. Definitely, there is nothing new. But yes, there is a new case thing that AI is not only made for this. AI will make ease your day-to-day life. These hematology hurdles will be removed by AI. And that's why I am going to start with my first case. That first case is, so before going that, I'm not going to share any fancy case. Please remember that I am very small lab owner. I use average of 30 labs and hardly 1 or 2 smears daily. And that too, 1 or 2 cases of leukemia. So not everyday leukemia cases. So hit case one is a Putti story. This guy is around uh, 12 or 15 years old, happy-go-lucky guy who was doing his preparations for exams, and suddenly he got bone pain and fever. So nearest doctor was the orthopedic surgeon. He went with the father. Uh, that orthopedic person gave him some drugs, but after 2 days, then it was constant. So there is a saying that, or you trust to someone else. For example, I have a 8 year kid. So in my house, everybody says that my closest friend, his pediatrician, until and unless he will not touch my boy, he will not touch my son, he will not get cured. Something like that happens many times. It is not superstitious, but it is believed that the person who knows my child since childhood will treat him very better. So that's how his father think. He has been vaccinated at senior pediatrician. So he came back to the pediatrician, and pediatrician checked it. He ordered some basic test. Any clinicians will order, that is the CBC and CRP. With that, he added the dengue. And the outside reports were like 8,000 WBC, 9 hemoglobin, and platelet 30,000. I don't know about the dengue results. So that was outside reports. But after they suspicious it's dengue, second day, that means from the day he got the fever to the day he admitted to a pediatrician, 5 days has been gone. On the fifth day, pediatrician suspicious something that it's not a normal dengue fever. Let's do a PS again. And they send a PS. And the funny thing is, they send PS to me for a different reason. Sir is a senior pediatrician, very known pediatrician. He saw one or two reports of one of cases, and there are the pictures of that report with the PS reports when we go through AI 1000. So he thought, okay, he's giving with proof, so let's send to the Chaitanya. And they sent to me. We scanned it, and after scanning, this is the full term. So there is nothing abnormal. WBC 6,800 again, hemoglobin 8.8. RBC was little normal side, but lower side. Okay, platelet was decreased, and even graph was showing, okay, it is going to be a dengue. So this is how basically Mandara software looks. Just now, Dr. Renu has shown you how exactly it looks. And you can see here clearly that there are the 4 5 parts. One is the summary. Actually, when you get into the software reporting, you come first this summary part. But I always avoid the summary part and I will go ulta for microscopic view. The reason is because when we go for the microscopic view, I feel like I am seeing in the microscope. So these are the panels of slide. You can put any point of the slide and you can see, and hover your mouse on that, you can see the maximize size or zoom side, and then you can decide. So I go to the microscopic view, malaria, platelet, RBC, like that. I usually start ulta. And in this case also, I went like that. Okay, neutrophils are okay, band okay, lymphocytes is reactive. So it was prejudiced that okay, it is going to be a dengue. I made my mind. But when I jumped to the blast, atypical blasts shocked me a lot, because you can see this much loss are definitely a worrisome thing, and it's not a good thing for me nor for patient. So and I jumped to the summary report. I got shocked. 54 lymphocytes and 32% blast. Immediately I typed the report, I added the photographs ASAP. I told to my technician, run to the hospital, give this report in hand of clinician, not to the patient. And as soon as the clinician got the report, he called me, and there was only one word. Are you sure, Dr. Chaitanya? I say, sir, sure, definitely sure. It's going to be a leukemia. What happened next is, next morning, he sent patient to the Sambhajinagar. First train he got at 6 a.m. and he sent it to the Sambhajinagar. There, the hematologist did bone marrow, flow cytometry, everything has been done. And after the follow-up in evening, we come to know, yes, it is a ALL, definitely. After flow cytometry, it was diagnosed as a B cell ALL, and now patient is under the treatment. So this Kutti story taught me a lot. This story actually taught me a lot, because I will not say this 5 days undiagnosed case, but there was missing something link between this. You can see the clear difference from 5 days to 48 hours. The PS we got, lab alerted, and immediately referral and fast track management gives that within a 48 hours, patient started to get the treatment. This is a huge achievement. In fact, this will come to me even also with the traditional way. The number of blast will be always a confusing account or number for me. In fact, if I were not having this AI machine, I will also take more than 6 to 7 hours or maybe 12 hours to take second, third, fourth opinion, or to confirm from the others, to take the opinion of my partner, to take the opinion from seniors. So this is the trust building thing, bold decision. We gave it. And with that, I got the confidence that now my AI machine is running well. I can take the strong decisions and my confidence boosted up. So coming to the second case, actually, this is my first case which I diagnosed with AI. And this case also taught me a lot. 31st March, remember for one thing that is the chill day for us, because we don't do transaction on that day. And so with this, around 6 p.m., I got a call from other pathologist. Sir, I just reached at home and I got one sample for PS at my lab. Uh, would you do a favor to me, and you have a scanner now, can you do it for me? I say, yes, ma'am, I will definitely do. Without hesitation, I told. But fact was, I was also traveling myself, and still I accepted the sample. Sample collected at that lab came to my lab, and with that, they give us that WBC is 3,400, hemoglobin 10, and platelet was 8 lakh. There was nothing abnormal. Patient was absolutely walking, no headache, no chest pain, nothing. Only thing was again a fever which was recurring. That's it. So we did a scan, and again I was shocked. It was huge shock for me. The reason is I got this. The blast were almost 64%. This 64% blast alerted me too much. I immediately said my technician to go and resample again. The reason is sample was not collected at my lab. So I asked them to go and collect the sample. And then after that, again, we scanned. Before coming that, I was actually, I was in travel only. I was doing all these things remotely, but there was a mixed feeling. I remember the day when I signed my first SCC report of oral cancer when I joined as assistant professor. Definitely it is painful for patient, but for me, uh, it was exciting to sign the cancer report. And the same feeling came at this time. We are traveling, we have AI machine, and we have a leukemia. Definitely, I was praying for I was praying to God for the patient. It was very mixed feeling. I signed the report and again sent to the ma'am on the WhatsApp only. First, she surprised, but she trusted me that I gave the report correctly. This is the exact screenshot of our chart. You can see she said, "Okay, sir, thank you very much for the report." The surprising fact for me was not dancing the robot. Surprising fact was this. Actually, she sent me a screenshot of filter on the 524, and you can see the time at the 6:13 we delivered the report. I mean, less than a 45 minutes or 50 minutes we delivered a leukemia report to the patient. So patient again went to this, and in fact, this was the first case. I posted it on social media. I became Now I started to post the cases with this case only. I started all these things, but this case also taught me one thing that my teacher always used to say that British didn't just teach medicine, they taught us how to keep a record, which I made a mistake to keeping a record. That's why I was not having the screenshot or photograph of the sample run in my lab. So with this case, I started to keep the records of my all AI samples now, scanners samples now. And this case really taught me, not because of this, but one thing I got it. You can take a bold call with the AI. I become a confidence, and the clarity which I got from this was amazing. I already told our relations got strengthened with the clinician because this case is not only my first case, but this case came from the super physician. At every place you praise the one physician as a god, and this is the one physician from whom I got this case, and I diagnosed it, and he immediately referred case to the Sambhajinagar. So the Sambhajinagar is nearest to us by 3 hours, and we have almost 8 to 9 hematologists over there. That's why most of the cases goes there. Now coming to my third case, that is the phantom fall, and my partner, Dr. Shivkanya's husband, is cardiologist, and my almost most of the samples come from their hospitals. So around 3 a.m. we got the patient with chest pain, weakness, and mild fever. So he was having outside report of platelet less than 20,000. They ordered the ECG. ECG was normal, so they stopped to order for CKMB and tropa. But they sent CBC again to confirm it because their suspicious was dengue and not the EMI. So what happened next is CBC come to my lab. I have some specific SOP when to do PS and what to do with the sample, because I believe in one thing: man fails, system work. So I made a systems in my lab of SOPs. If you got hemoglobin less than 10, if you got platelet less than 1.2 lakh, and WBC is more than 50,000, PS is compulsory, whatever it may be, because my lab runs 24/7. So whoever on the duty who got this sample has to make this PS in traditional way. Second thing is, not only this, he has to run again back, take a repeat fresh sample, rerun that sample, and then only inform me with graph. If you are running once and informing me, sir, graph is abnormal or sir, sample is having low platelet, not acceptable. You have to do this. You have to take a sample again, irrespective of any test, PTNR, lipid, CBC, anything. So what happen is, you can see here, WBCs are 60,000, hemoglobin normal, and platelet 26,000. You can see even graph also not showing any abnormality. So I thought, okay, it's okay. There was no abnormality. They scanned. My senior technician was on the duty that day, and early morning he called me at 7 o'clock only. Sir, we scanned the slide already. Just check it out. I checked the slide, and reports were these. These are the platelet clumps. So it was a clear-cut case of pseudothrombocytopenia, which was in EDTA induced. If it was like, immediately I informed to the physician that stop all this test for next 6 hours. Don't do anything for next 6 hours. Just keep quiet. We will see other things and we will sue. Because if this was happened to me even before AI machine, it may take time. Usually I come at 10 a.m. Some may come at 9 a.m. Someone may come at 11 a.m. So usually reviewing a slide at such a long hours, it will take 7 to 8 hours to review the slide, late night slides. And then this clinical impact taught me a lot. First was the time saving. Second, I learned is the money saving, and third is the policy change. So first one was that this came at 3 a.m. and we diagnosed at 7 a.m. Okay, I can do it still earlier, but there were different reasons also. Taking a money and convincing a patient at late night or late morning, early morning is very difficult task at my place. If you say to the patient, you have to pay 200 rupees for CBC and 200 rupees for PS, he will scream like anything. We have done a CBC just now. Why we should pay 200 extra? So they will fight like anything. They don't know that their technician lab is different. See, in my case also, even if I have not reviewed this slide, this, if you run the sample at any lab, any machine, anywhere in the world, it was going to give a same result. It was labeled as thrombocytopenia. So it's very difficult to convince, and that's why it take a time. So, but still we did a better thing. 7 o'clock, we diagnosed the case that it's pseudothrombocytopenia. What happened next is, because of just not only diagnosing the pseudothrombocytopenia, also we diagnosed with the AI only, it is not malaria, because gold standard test for the slide screening is the for the malaria is the slide screening, and we did it on the AI. It did well, and we told to doctor it is not malaria and it is not a thrombocytopenia, it is a pseudo thrombocytopenia. So we stopped the other dengue kit states, LFT, KFT, all other test has been stopped. Patient was only on just normal saline, and after 8 hours he was relieved from the hospital. So he is like, I'm telling you 5,000 rupees just at my place. Imagine that this cost will be at the Apollo or Metro cities will go more than 20,000 for only investigations to the patient. Sonography and everything will be added. It goes to the 30,000 maybe. And we save this much money. With that, we also save the patient don't need to stay in hospital. He was relieved from the hospital immediately. Next was, before that, this case, we were doing that resampling first. Now we change our protocol and we go to the scan first, resample later. And next day, immediately we got next case, because as I told, my partner's husband is cardiologist. So we get angioplasty cases. So post angioplasty on the day two, we advise minimum CBC, lipid, HbA1c, and depend on his other conditions like thyroid and other tests will be added. What happened next is that we got the angioplasty patient day two and we got hemoglobin 5 platelet low. So we changed the protocol now. Scan first, resample later. So what my technician did, he scanned the slide, but smear was normal. So it was a surprise to me. And, until I give the report, no one was like stopped at the same place. He also called already why post-plasty patient is getting hemoglobin low, because it is a worrisome sign. It may possible that he is having internal bleeding. It may possible that, and that is dreaded complication. So CBA like complication may happen to the patients. So we were running, but one thing made a mistake from my technician, that we have all fully automated biochemistry and HbA1c machines. So he put the samples with all morning samples and he put the machine on. So what happened is our lipid has been done, which shows the lower side and HbA1c become abnormal. So till then we got the history also, and we were like the fault was from the collection boy. He collected it and it was a dilutional error. So AI, like in this case, if we can stop this money also, we can stop the wastage of lipid and HbA1c kits also if we reviewed the slide earlier, and if my morning sample person will stop that before reporting to me or be waiting for my reports. And what happened is this, from here again we started that low hemoglobin sample should not be run until and unless I reviewed the slide. So it changes a lot in my case. Coming to the last case, case 4, that is rage in silence. Why I gave this? Because this is the most readiest case in my life, in my whole life, 10 years of career. Uh, One of my pediatric friend, uh, he got a case at around 10 p.m. at night. Case was mild fever, sluggishness, and drowsiness. So as usual, he gave the CBC and CRP, ordered that, and usually at night, what we do is once I left the lab, I won't allow or I won't authorize any reports without my physical presence. So what we do is in emergency cases, we share the screenshot to the doctor with my permission. First, I will review and then it will go to the doctor. What happened is without me bypassing me in a hurry, my technician shared the screenshot directly to the pediatrician. And you can see that WBC 40,000, CRP normal. As soon as the person that doctor got this report, he called me. My nickname is Anna in my college, and he is my UG friend. So he called me, Anna, what you are doing at 40,000 count and you are sharing just only screenshot? You should call me immediately. I told, see, I am not in a lab because I was traveling again. And every time I saw whenever I am traveling, there will be a card at my lab. There will be some biggest case will come to my lab. So I called to my technician. He says, sorry, sir. In a hurry, I did. I said, okay, but now what to do? So I called to the uh, clinician also. So let's thought that because he was a new, he was untrained. So I gave him a question, Ulta. What he will do if your nearest one is doing like this? What he will do in this situation? So he immediately took action. He called my senior technician and he asked how to do PS and everything. So here I will reveal you one secret thing that we have one machine at our lab, which is called as the PS smear making machine. Okay. So this is the PS smear making machine. You just put the slide, you just put the drop, you just click the button, smear is ready. And with the photographs and everything and on the call support, he stayed somehow and he scanned it. Simply he scanned it without any training. And I got the reports. Reports were more shocking to me than the leukemia. Everything was normal except the toxic granules and blast were not there. So I was in a worry what to do. Hemoglobin normal, platelet normal, no shift to left, only toxic granules. I called to again back and I told him, see, it's not leukemia and not sepsis also. So now the ball was in a court of pediatrician and he was in a worry state. 40,000, he was okay. Okay, this patient is going to be leukemia. Now he is in worry. If this is not leukemia, what is this? Because patient don't have any sepsis signs. Patient don't have anything. So before going to sleep at around 11 o'clock, 12 o'clock, he thought, let's go back and see again once back to the patient how he is doing well. And when he inquired more questions, he got shocked himself that 3 days before coming to his hospital at late night, they took this patient to some quack. I will tell you, this is the very dreaded story because this was a precious baby. It was born after 17 years to the couple, and they took the quack because of some reason I don't know. And that quack thrown some water on him. And since then, he was frightened. Since then, he was not taking water. He was very unhappy. He was drowsy, and that clicks his mind that how come at a 40 degrees Celsius, that time it was 40 degrees. Parbhani is one of the top 10 cities in the India where we get around almost 45, 46 degrees Celsius temperature. How A baby of 3 years cannot take a single drop of water in a 24 hours at 40 degrees Celsius. He got immediately suspicious, and what he did is he brought a water bottle in front of him. Baby screamed. It was hydrophobia, a very dangerous sign, because everybody knows hydrophobia comes for what? He immediately at night only he shifted the patient for full night. We were in contact with the parents. I was contact with the doctor. Doctor is contact with the parents, and they shifted to the tertiary care. And in morning he shifted to the another more higher center. Till then, that 12 hours were gone, and in that 12 hours he developed even aerophagia, and case was diagnosed as a rabies. Till today, just day before yesterday, I met to the pediatrician. He was shivering because if Chaitanya, you would have not told me that is this is the case of not a leukemia, whole hospital will get infectious. Okay, definitely it was a bad side that we told that it is not a leukemia. It was an exclusion diagnosis, but still it is very important as good as we are diagnosing leukemia, because when you are not diagnosing it is not a leukemia, then it will trigger the point that then what it is. It helps to eliminate what it is not. That means it redirect clinicians to think what it is. And until and unless you don't diagnose the case, you will not give a correct treatment. The other side of this is okay, we were not able to change the end point of this case, but we tried to I will say we avert more dreaded complications, that whole hospital may get infected, doctor may get infected, and whole scenario will be different. Till today, day before yesterday, I met, he was shivering, that reminding this case. And also we were feeling so bad for the same case, that the boy born after 17 years to the couple died because of rabies, and that too without history of dog bite. Till date, we don't know what it is, how it happened, whatever it may be. I don't want to go in a deeper clinical perspective, but the AI help us here to rule out the thing. So till this case, I was thinking, okay, AI is for only diagnosis. No, AI is for your daily life. And that's what I learned from these daily cases. So till for 4 cases, I am running through hit. So what hit is, it is not a picture actually name. It is the story I myself gave it as a hematology investigation tells, and hope I will continue with this. So with every machine, you get every more challenges. With this machine also, I get challenges. The smear making, the first most important challenge I got, I already explained that why it is, because once technician changed, everything changed. So it was my biggest problem. I brought a small local made machine which made a smear. Why I brought a small machine instead of automation is very simple, because I'm today I get only 2 or 3 smears. Okay, I brought AI. Everybody's thinking why you brought AI at this stage, because I know that now I am very happy that even if I am in a losses, I am able to give a society what it needs at what time. I was able to save the patient. I was able to give the standard reports, and I was able to serve the society at the same time. And the most important, I will discuss this in the last slide, how it helped me instead of that money. Because always we count CPT. It's not about CPT or CPRT. It's about life and death. It's about your enjoyness, and it about easiness. So I will tell you the side effects later on. So the second challenge till date today we have is a post-scan slide washing. I tried to teach our Maushi and Mama how to wash the slide, but still we are not getting good results. So how we overcome is right now, if we suspicious problem, what we do is we use always a new slide. Okay, 50 paisas are charging more, but we are using new slides then when we are not getting a clean slide. So what are my reflections after using this AI diagnosis to us? First, it cut delays from days to hours. You can imagine that within a 48 hours patient can get treatment. Within a 12 hours patient can diagnose it is not leukemia. It is a huge thing. Second thing is my technician dependency has been come down and junior technicians became empowered. In my case, the I saw that the technician to whom we never show even how to start a machine, he scanned this slide. This is a huge achievement for ourselves. To the technician, he got so much confidence that he is doing single-handedly now my all-night reports. Third, we got is I got confidence in emergency duties from home only, or even if I'm traveling, I can do the reporting. Next is avoid the wrong treatments. In case of rabies, I told, instead of giving the rabies treatment, if we were have landed up in the leukemia. And the last is it build trust with the clinicians. So this is what AI reflection is for me. AI changed the whole scenario for day-to-day reporting for me. So what are the indirect effects? That's what I was talking about. First one was when before this machine, we were thinking to take a 7-part machine. It reduced my cost of 7 part. Second is my technical dependency has been gone. So we are very calm now. We don't need to search more senior technicians. We can train a junior technician and we can handle the lab. No more late night lab visits. See, morning 3 o'clock, you have to come to the lab, you have to report again, go back. It's very hectic. It's not an easy thing, and that to day-to-day life. So I can spend more time with my family when it needs most or it matter most. So my balance is increased. Next two are very important me because indirect effect also cost me the traveling and fuel cost. See, we never count this, but in India, we know 107 rupees per liter costing is very important. You have to add this cost in your CBC cost, PS cost also when you are visiting back to the doctor. This even though I am staying at the small town district place, but still it takes 5 kilometer come and 5 kilometer go, 10 kilometer. So for imagine for the other people, those who are from senior like metro cities, they are losing more time. More money in this. I use this to write a book. I wrote 2 books. I am author of 2 books now. So I use this time. And second, I launched my 2 ventures, soft skill training. I just started an AI health startup. I'm not talking about all these things, but see, these ideas were in my mind before also since 10 years. But I was able to do all these things right now because when I was working with traditionally without AI, that time I was exhausted. My mind was exhausted. Now I have a quality time with my family and I have quality productive time to do what I want to do. I want to invest this time somewhere else. So that's what thing. And last thing I want to like to say is that AI created a moments where it didn't replace me. It is biggest fear that AI will replace me. No, rather I will say it amplified me. I'm doing more work. I'm doing more projects. Sorry for my voice. So I'm doing the more projects, and what I think is that in future also, AI will not replace the person, but AI will replace the person. The person who knows AI will replace the person who don't know the AI. So that's what my take. Thank you very much. You can reach me on my WhatsApp or you can follow me on Twitter. And thank you very much, SigTuple, Dr. Renu, and all for giving me this opportunity. If any questions, where is open to the discussion.
Thank you, Dr. Chaitanya. Before I give my closing remarks, I would like to ask the audience out over here. I'm sure they would have loved this invigorating session. It definitely inspired me in many ways, and it reminded me of the times when I was in practice in the lab. And whether you are in a peripheral area or you are in a metro, a lot of these things are something that we come across in our day to day practice and something to be very alert and vigilant about. Clinical history is important, but it's really important to also look out, think outside the box and think what other possibilities can actually be present and not just going by what you're just seeing. And probably tools like technological tools like AI based tools help to alert us and aid us, especially when you are driven during the entire day. You don't have time, you're fatigued, or you have so many slides to look at least such critical points can be put across in front of you for your alertness. And that's where I think an AI tool gives you that value add in showing that there is something more than what actually meets the eye in such cases. And as you rightly said, it's so important to have the trust and communication with the clinicians so that there is a double dialogue out over there. It's never a one-way street. We get clinical history from them, we share what we are thinking, we aid them to think further and to dwell further and deeper into the diagnosis to see what else can actually come out of it. And all the cases have been represented so beautifully where we thought it could be something else and it turned out to be something else. And spurious thrombocytopenia is something I have myself encountered so many times in the lab. And it comes in hours, when you don't expect it, very early hours of the morning morning, late nights, or before a blood transfusion. It's so wonderful to actually see those images of platelet clumps where you can very confidently tell your clinician that platelets are adequate on smear. And I think that's one of the commonest errors that actually happen in the lab when a low count is given in haste without actually looking for platelet clumps. I could go on and on, but before I can conclude and bring a closure to this entire webinar, I would like to hand it over to the audience. Please do share with us. Let us know what are the kinds of errors you have faced or challenges that you have faced in your situations of practice. We'd be very happy to hear that right now in the session. And Dr. Chaitanya will be very happy, in fact, to take those questions. So if anybody has a question, just please raise your hand, or you can just unmute yourself and also ask us a question right now. I think we have it in the chat box, no dog bite, then how rabies. But I think that's something Dr. Chaitanya addressed. If you'd like to throw some further insight into that, sir, on that question, this is by Dr.
Uh,
Kanchana
I,
Doshi.
I would like to say that thing. Definitely, this question was very question for debate at our place, and we contacted seniors. We contacted the person who diagnosed this case rabies at Sambhajinagar also, because that boy died in sedation only, because we have to sedate that boy person, and that baby died in sedation only. So what I got from the clinician's back report is that it may quite possible he was having some bite from other than the dog, which was overlooked by the parents, or it may quite possible that he had a milk which was contaminated by rabies, because rabies dormant period is very long. So that's what I got it. But finally, it was diagnosed as a rabies because PM report is still awaiting. But it was damn sure it was given on his PM report also.
Do we have any more questions or feedback? Or if somebody would like to just talk about a challenging case that they have had in their practice, we'd like to hear that over here in this forum as well. Whether it was assisted with AI or not, or with any kind of technology or not, that doesn't matter. What's important is whether you are looking at a manual microscopic view or you're going to be using with an AI assisted tool. It's very important to keep our antennas open all the time, because sometimes what it seems, it's not that. And, as the saying goes, the eyes don't see what the mind doesn't know. So very important to have that knowledge and how you can apply that knowledge when you're actually assessing a case. And we are all clinicians first and then pathologists. Clinical history, clinical acumen, what is seen in the morphology, the insights that we derive by looking at the morphology on a peripheral blood smear. And the peripheral blood smear is one of the most important screening tools as of even till today. It is a cornerstone, a gold standard from which we get a lot of clues, and that paves the path for further evaluation and performing the right tests, so that you can actually not do the wrong tests and save the time and money for the lab and for the patient as well, without doing unnecessary tests, and give the right diagnosis to your clinician. So AI adoption is not something to be perturbed about or felt insecure about. It definitely aids the pathologist, doesn't replace the pathologist, and helps you to give faster, smarter, and more meaningful and quality-driven reports. So if there's anything that somebody would like to reach out to, maybe not now. Dr. Chaitanya has also shared his number, and I'm sure Mr. Manohar Adaka has shared our contacts as well in the email. We'd be very happy to reach out to look at any kind of queries that you would like to have. And if you would like to have a look into further insights, to take further insights into AI 100 and the operations of AI 100, we'll be more than happy to even have a demo at your place. And but yes, would like to continue this as a community, the network, where we can all come together and discuss important cases, and that way we educate each other. And I think that's a thing that needs to grow, and that's how we will be also empowered, going further, adopting technologies, and see how we can apply them in our day-to-day lives. So I thank again each and every one of you present here today. Thank you, Dr. Chaitanya, for taking out the time, and especially, having a sore throat for the last 1 week. That was really great of you to have managed that and somehow be available for the meeting here today. Thank you, sir. And we hope to have more insights from you on the LinkedIn platform. So all of you present here today, please do check out Dr. Chaitanya on LinkedIn, and he keeps posting some amazing stories out over there. And as he said, he's going to create a book on this, and we await that as well. When that is being published, to take out these valuable nuggets and keep that in mind in our practices as well in future. Thank you, Dr.
Thank you.
Chaitanya.
Thank you. Thank you,
Thank
everybody.
you.
Thank you.
Thank you for a wonderful audience who's joined us on this beautiful Saturday evening. Thank you, Manohar Daka, for all the operations from your end as well, making this webinar happen today. And yes, I would like to end and conclude the webinar, and all of you wishing you a very happy weekend.